choose to do this for high-grade glioma. So everybody knows, and it was very well described, the utility of radiotherapy in newly diagnosed glioblastoma, and this has been well established since the early 60s and 70s, that we could improve overall survival with the appropriate use of radiotherapy. And everybody knows this graph, and I just wanted to show that this is the baseline of what we have at this point in time for patients with glioblastoma. And what is interesting is that there are patients who are now surviving past 12 months and 24 months and 36 months. And when these patients recur or progress, what do we do then? So what are our options for progressive high-grade glioma at this time? We have experimental studies, and we need to continue doing those because that's the only way we're going to make things progress. But most of the time, unfortunately, the results have been so-so. So we have to think about what other options there are if there isn't an appropriate experimental study for the particular patient. We have salvage chemotherapy, which is based on the available cytotoxic drugs. We have surgery, and surgery is actually a very good, appropriate intervention for a recurrent high-grade glioma, where the patient is medically fit and that the tumor is accessible. And then we have re-irradiation. And it's interesting, over the past 2 or 3 years, re-irradiation has become more popular and more fashionable, I should say, within my environment, and so I'm being asked a lot more about this. So when we're talking about re-irradiation for high-grade glioma, the same questions come up as to how to go about doing it. For external beam radiotherapy, we have to think about the fractionation, what volume are we going to be treating, what's the dose, and what is the technique. And these are all questions, and there are questions still left in primary management, and there's even more questions about recurrent disease. There's stereotactic radiosurgery approaches, and then there's brachytherapy. So how do we decide which technique? What are the best imaging techniques for delineation, outcome, and then necrosis, because the treatment itself can cause problems? What are the benefits? Are we doing this just because we can? Is the patient improving their quality of life? Are we changing overall survival? What are the toxicities? And how do we combine this with all the other modalities? So these are questions that have not been fully answered. So one experience, this is from Germany, the same group who has the ongoing study for glioblastoma, where they looked at fractionated stereotactic radiotherapy. They looked at all gliomas, but I'm going to concentrate more on the high-grade gliomas here. They had 42 anaplastic astrocytomas and 59 glioblastomas. They used the mask for immobilization, so that was more comfortable for the patient. They used linear accelerator-based radiotherapy. Their PTV was just the contrast-enhancing abnormality with a 0.5 to 1 centimeter tumor. So again, when we're doing re-irradiation, our volumes tend to be smaller. Median dose was 36 gray in 2 gray fractions. So it was taking about 3.5, 4 weeks to deliver. In their experience, toxicity, they had alopecia, headaches, nausea, vomiting, and skin erythema. All managed quite well, and they had one patient who had histologic necrosis. So this was their experience. Again, looking just at the high-grade gliomas, the median age at diagnosis was 30 younger for the anaplastic astrocytomas versus the glioblastomas. They were selective about who they treated. They chose patients who had performance status that were still good. The median time from the first radiotherapy in the anaplastic astrocytomas was 32 months, and for the glioblastomas was 10 months. So this is a question: how soon can we re-irradiate patients after the first radiation? So the median overall survival from diagnosis in this cohort, 50 months for anaplastic astrocytoma, 21 months for glioblastoma, and median overall survival from the re-irradiation was 16 and 8 months. So they achieved 8 more months of overall survival in the high-grade, in the glioblastomas, and progression-free survival was about half a year in both groups. So what they noticed was their overall survival predictors were great, as we expect, extent of resection, age at diagnosis. Those are things that are already been established by the RPA, And then after re-irradiation, time to progression was important. So maybe we need to look at patients who have had a longer duration of disease control and histology. These are their overall survival curves from diagnosis and from re-irradiation. You'll notice that for the red line, the glioblastoma still goes down, but there were some people who were surviving for over a year in the glioblastoma studies. So the RTOG did a phase 1 dose escalation for hyperfractionated stereotactic radiotherapy. So this was an ongoing study. Actually was done in 1994, 1996, and they had 25 lesions in 20 patients, mostly glioblastoma. And they had a dose escalation scheme looking at 3 grade fractions. They went from 7 fractions to 8 fractions to 10 fractions. And then in the last part, they went to 3.5 grade fractions for 10 fractions. So they did a dose escalation as well as a dose per fraction escalation. They used X-knife planning system, which is quite available. Their median tumor volume was 12.6 cc's, but it went up to 47. So they did pick slightly larger tumors. And their GTV was the T1 contrast. So on their experience, no grade 3 toxicities were reported. There was no reoperation for necrosis, but 5 patients had reoperation for progressive disease. Median overall survival here was 10.5 months. So not bad, we're getting closer to a year. Neurologic improvement in 45% of the patients, decreased steroid use in 60%, and there was imaging response in those patients who had the higher dose. So this is actually quite promising that re-irradiation is a useful tool. So for recurrent glioblastoma, I just picked out some studies that looked at radiosurgery and brachytherapy because these are 2 technologies that can be used, and there's some literature on it. But if you look at the green box there, median survival for all of the experience between 8 and 12 months, closer to an 11 and 12 months. I've looked at our own experience looking radiosurgery for recurrent glioblastomas, and our median survival after re-irradiation was 11 months. Reoperation rates are about 1 in 5 patients needed reoperation for necrosis or something. Gliocyte is a technology that's still available. It's been on and off the market. It's actually intracavitary brachytherapy. And this is their experience for re-irradiation for recurrent high-grade glioma. They treated 95 patients. They did maximal debulking, then inserted the device, which is shown there. Then afterwards, I-125 isotope is put into the device. And what they noticed was that their median survival was 9 months for glioblastoma, and 10.5 months for those high-grade gliomas that were not glioblastoma. They had 3 cases of radiotherapy necrosis proven by pathology. So here's another way of getting re-irradiation in. So all of these approaches for stereotactic radiosurgery, advantages are we're outpatient, single fraction, there's a sharp penumbra, it's highly conformal, and there may be a different radiobiology going on with a big dose of radiation versus multiple small doses. Disadvantages, there's size limitation, we can't be close to a critical structure, there's increased risk of necrosis, and we're limiting it to the tumor volume that you see. There's no room for a margin for microscopic disease. So I did a study, this was a few years ago, just looking at whether stereotactic radiosurgery or surgery would be better in a selected group of patients. And I did a matched cohort study looking at those patients that had received radiosurgery with glioblastoma versus those patients who would have been candidates but did not receive it. And you can see that both cases and controls, meaning those patients who had surgery or radiosurgery, did equally well. And so maybe this is an option where we can look at either surgery or radiosurgery as a salvage technique for selected patients. Fractionated stereotactic versus stereotactic, this is looking at fractionation of these patients. Here's a study by Cho looking at 46 patients who received radiosurgery, single fraction, versus 25 patients who had fractionated stereotactic radiotherapy. So in general, the doses, 37.5 gray fractionated, just because we're giving smaller fractions per day. Median overall survival close to a year in both groups. But the big difference was the late toxicities. 30% of our patients in the radiosurgery had late toxicities versus 8%. So this would suggest that maybe fractionation is gentler on the patient with possibly equal outcome, and you could actually even treat larger tumors. So what to do about bevacizumab failures, and what to do with bevacizumab, and what to do with all of the chemotherapy agents that we come across now in the more modern area. This isn't from 2010. This is a group of patients that were treated with fractionated stereotactic radiotherapy or stereotactic radiosurgery plus bevacizumab and chemotherapy, so usually temozolomide. And we look at this, the MRI response for the fractionated stereotactic radiotherapy group versus the non-radiotherapy group. The MRI response is 22% versus 0%. The post-salvage overall survival was larger in the fractionated, the radiotherapy group, and progression-free survival was also larger in the radiotherapy group. So this would suggest that even if we're salvaging with systemic therapy, say bevacizumab or chemotherapy, incorporating radiotherapy on top of that might be a good way to go. I just added this because I thought it was interesting. I'm not sure how many groups are actually doing this, but it's actually giving salvage radiotherapy at a very, very low dose rate per day. So essentially, it's giving 2 gray per day, but instead of taking 1 or 2 minutes to deliver the radiotherapy, they're taking 30 minutes to give the radiotherapy over the course of that one episode. And they repeat this over and over again. The median dose that they were giving on re-irradiation was another 50 gray. So radiobiologically, it's felt that if you give the radiation at a very, very low dose rate, that there's going to be more tolerance of the normal tissues. Their overall survival for recurrent glioblastoma was 5.1 months. So it's not really as good as the other experiences that I've shared with you. However, they did take a larger tumor recurrence volumes, and they were giving a larger volume in general. So their tumor volume was 403 cc's compared to the 12 or the 20 that I spoke about before. Their margin that they gave was 2 centimeters beyond the T2. So they were really going back and repeating the same types of volumes. But the approach is interesting. I'm not sure what to make of it. So the Japanese group here, Mizumoto, looked at their experience looking at 3D radiotherapy, stereotactic radiotherapy, and proton radiotherapy. Overall, they did not see a difference in outcome, but their suggestion was that there was a benefit to re-irradiation again, and that that the technique wasn't necessarily that important in their hands that for overall survival and local control. Quality of life. This is really something that we need to look at. Nider et al. Looked at the literature and tried to identify what type of quality of life benefits re-irradiation could confer. They looked at 300 patients. 6-month progression-free survival was anywhere around 30%. 1-year overall survival, 18 to 48% across the board. And then without chemotherapy, the median survival is 26%. So the chemotherapy seems to be useful. If you had a KPS of less than 70 at the time of re-irradiation, there was an increased risk of progression and less effective re-irradiation. So this suggests that we need to pick our patients who we're considering re-irradiation for carefully. Steroid reduction happened in about 20 to 60% of the patients. Serious late toxicities were uncommon after fractionated radiotherapy. So this suggests that we need to select our patients well, that there can be clinical outcomes that are good, the use of chemotherapy with recurrent disease is appropriate, and in their experience, even fractions of 3 to 5 gray were tolerated well. So the hypofractionated approach was okay. Re-irradiation and temozolomide, this is another group of patients that we've been looking at. And what this was suggesting was that there is really no increased toxicities, and the median interval from first radiotherapy in this group was 15 months, so they selected out patients who had actually survived a long time, so maybe they were picking good people. Median overall survival in this group, 11.4 months for glioblastoma, and 16 months for anaplastic astrocytoma. So we're still stuck at that 10 to 12 months. And there was radiation necrosis with neurologic symptoms in 4 patients in this group. This is a patient that I'm treating right now, and this just makes me feel good, and I wanted to share it with you. She was 19 years old at the time of original diagnosis in May 2004, and this was a real glioblastoma, no funny business there. And up until June 2012, after surgery, radiation, she was not on temozolomide during radiation, but she received it subsequently. June 2012, her scan looked really great. By May 2013, she developed this area of enhancement, and this was resected, and it was found to be recurrent glioblastoma 9 years after her original diagnosis. So we're treating her. She's 28 years old, and we're retreating her with protons and temozolomide. Hopefully she'll do okay. So there are studies, and we have to think about what can we incorporate with re-irradiation. Do we want to use bevacizumab? There's studies evaluating carboplatin and etoposide. So far, all of the studies suggest that there's reasonable tolerance, but there's been no major advantage seen so far, except for that one study that I talked about. There's a study now that's ongoing for re-irradiation through the RTOG. It's RTOG 1205. The experimental arm is adding radiotherapy on top of bevacizumab for recurrent disease. And so what they're doing is they're giving 35 gray in 10 fractions on top of Q2 week bevacizumab, and then that continues afterwards. So the primary objective here is to look at the improvement in overall survival in glioblastoma patients with adding radiotherapy, re-irradiation to bevacizumab versus bevacizumab alone. Secondary objectives are to look at the objective response, 6-month performance, progression-free survival, and to estimate grade 3 toxicities. Eligibility, they have to be at least 6 months from the original diagnosis, original completion of radiotherapy, or it has to be a new area of disease, biopsy-proven or persistent and recurrent disease, or MRS, MR perfusion, or PET-proven active disease. So if you have these new changes before 6 months, you're still eligible for this study. They are even allowed to have had prior radiosurgery or brachytherapy if number 1, 2, or 3 are met. So they're really looking for active disease that's been proven. Less than 5 centimeters, no multifocal or infratentorial disease, and no prior VEGF inhibitor exposure. So that's ongoing, and we'll see how that goes. I just want to bring this up as a teaching point. This is a patient that I treated in March 2009, large cystic or large necrotic lesion in the left frontal lobe. Then in June 2012, 3 years later, she developed this new area of diffusion restriction that was abnormal and was picked up, and that was resected. She received 60 gray up front with temozolomide. At recurrence, she got 44 gray in 22 fractions with temozolomide, and you can see that we did this cumulative plan, and that area circled in white is where the 2 radiation plans actually overlapped, and that's where she developed necrosis in September 2012. So 3 months later, she developed radiation changes right in the high-dose area. So this shows that we do need to really think about what's been done in the past and consider these outcomes. So in December 2012, the necrosis was improving, but she had developed new nodularity. A year later, she's alive, she has progressive disease and worsening clinical symptoms. So despite our ability to clean up what's active, she developed new disease despite that. One last thing, this is Novo TTF, it's 100A system. This has been developed and it's FDA approved for recurrent glioblastoma. I have never used this device, but there are some centers that are starting to use it. And it's using 200 kilohertz electric fields, or called TT fields, and they are actually placed on the patient's head, and there's a perpendicular application of these fields sequentially to try and kill cancer cells. I don't understand all of the basic biology behind this, but it is something that's out there. You have to put it on the scalp, so you have to shave your head, and you have to wear it from 20 to 24 hours a day. This is, that lady down there is wearing it, and you have to carry this transducer around with you. They did a randomized study of chemotherapy versus the TTF, where they applied the TTF for at least 4 weeks. They did 237 patients. Compliance for use of this, the device was 84%, and 1-year overall survival is 20%. So the FDA has approved this on the basis of this, and the RTOG is looking at using this at some level for glioblastoma. I'm not sure how we're going to incorporate it. So what are the outstanding issues? What is the best way to identify progressive disease versus treatment-related changes? And we know about pseudoprogression, and we want to know better how to really identify these patients. How do we assess the response of re-irradiation, since the radiation itself is going to cause a lot of inflammatory changes? Some people may have considered that area of necrosis to be progressive disease in that case I showed. Is there a role for advanced imaging or PET scans? And that was nicely shown on the earlier talk about what MET-PET might be able to do. How do we optimize systemic therapy and re-irradiation, because there may be combined toxicities? So in summary, re-irradiation is a good tool for selected cases of patients with progressive high-grade glioma. Small lesions may be treated with radiosurgery, but you do have to watch out for toxicities. Larger lesions can be treated with fractionated approaches. Bevacizumab may be a good approach for sensitization and reduction in toxicities. And so that's kind of the approach that we're looking at right now ourselves. Thank you.